IL-17, and more specifically looking at the IL-17AF. So as you know, there are currently two IL-17AF in development. You've presented the results of the phase 2b results of sonelokimab, the Merck's nanobody, and there's also one from UCB, the bimekizumab.
They prefer to say BIMI.
BIMI, okay.
They prefer BIMI, yeah, as opposed to BIMI. I say BIMI, they say BIMI.
BIMI, okay. BIMI.
Yeah, so
you can buy it.
Kind to be kind to our Belgian friend, I will have to say BIMI. Bimekizumab.
Bimekizumab. So in general perception, how do you perceive the IL-17AF compared to the IL-17A?
Well, I actually don't see that there is, I'll say, material difference. What we see in from any of the pathways, any of the drugs that are effective at blocking key cytokines, excuse me, that are participating in the pathogenesis of an inflammatory condition, is that it's all about exposure, so the degree of blockade. So TNF antagonists are all very competent at achieving high levels of response. It's just that the TNF antagonists were developed for conditions or states other than psoriasis. And so the optimal dose for psoriasis was never used in the development of those products, with one exception. In the phase 2 study with Humira, the 40 milligram weekly dose was entertained for a brief period of time. But on the label dose was 40 milligrams every 2 weeks, which is not the optimal dose for treating psoriasis. Similarly, infliximab was initially developed for rheumatoid arthritis, and so the maintenance regimen was actually inappropriate for psoriasis. Effective, but it does not have durability, and similarly with the etanercept. Along comes the 2017 inhibitors, now, if we move forward a few years, and they have been optimized for response. So there are always limitations based upon what the preclinical work permits in terms of exposure. Once an advanced development plan is in place, it's very hard to amend the dosing regimen. And for that reason, we see that secukinumab, 300 milligrams monthly, does not enjoy the same maintenance of response as, say, ixekizumab, 80 milligrams monthly. Secukinumab is a less potent drug, and therefore it needs more to do the same job. And even at 300 milligrams, it does not achieve the same levels of response, nor does it maintain them, largely for pharmacological effects, as does ixekizumab. And now moving forward to sonelokimab or with bimekizumab, I'm going to say BIMI. I prefer BIMI. It sounds much nicer.
Okay.
Bimekizumab are just more potent inhibitors. But the actual target, the actual main MOA is exactly the same. So I just see them as being all in the same group. Fundamentally, there's no difference. The difference between the products is simply in the binding characteristics and in the pharmacology. What are their pharmacological properties in terms of bioavailability, half-life, and those sorts of things. Everything else falls out of that.
Okay. So any difference that you will see in efficacy or safety will not be related to the dual inhibition of the A and F?
No.
Is that what you mean? Okay.
So I wouldn't expect there, because the mechanistically, they actually act on exactly the same roles, or the same receptors. The difference is F is a detuned IL-17 player. It is not as it's actually more potent technically than A by maybe a little smidge, but the half-life is so short that its effective potency is much reduced. So it's not clear from an evolutionary perspective why we would have A and F, and it could be that F is somewhat protective when we look at, for example, the gut. That remains to be seen, but at least theoretically, it's possible that having A and F blockade will actually be beneficial compared to having A alone. The reason being, looking at the onset of Crohn's or ulcerative colitis, we did have one confirmed case in the bimekizumab program, but we don't seem to see as many as were evident in the other programs. Now, we have to wait until we have more patients exposed, but that's a tantalizing hint at the possibility that there's the advantage of an F blockade, that you can still get high levels of response, but reduce the, shall we say, the more worrisome issue, and that is the development of inflammatory bowel disease, which is clearly, I should say in my mind anyway, and based upon the analyses that I have, that clearly the implementation of 17A blockade instigates or potentiates the expression of inflammatory bowel disease in a susceptible population.
Okay, patients with
and it may be that instigation is less potent or less likely to occur if one also blocks F. That remains to be seen. It's tantalizing. There's a hint, but not yet quite enough data to say that's the case.
Okay. So, and you say that remains to be seen. Do you think that with the head-to-head trial comparing bimekizumab versus Cosentyx, we could see this as a potential safety advantage for bimekizumab?
Very little. The safety with the primary concerns with regard to safety are twofold. One is the development of inflammatory bowel disease, and there we see that SECU and ICSI are very similar in that regard. So there isn't a strong dose-response relationship. We see that the other safety concern, which is the development of candidiasis, and it's almost entirely oral pharyngeal, quote, esophageal, is strictly related to the degree of blockade. We see a dose-response relationship, both SECU and ICSI, and given that Bimi is arguably more potent than either of those two, it's not surprising that we see yet again a higher incidence of oral pharyngeal candidiasis in patients treated with Bimi compared to SECU or compared to ICSI. Okay,
so you're saying it's likely that we see higher incidence of
higher level of blockade is just associated with an increased risk of developing oropharyngeal candidiasis. So the way to think of these is from a pharmacodynamic perspective. So pharmacodynamics tells us that all of the responses are likely to fall, actually I'll say not likely, they must fall on a line that's described by a power curve. And the power curve that generally fits to biological systems is what's called the Langmuir-Hill equation. So either way around, either Hill-Langmuir, Langmuir-Hill, doesn't matter to me. I guess historically it should be Hill-Langmuir, or alphabetically anyway, Hill-Langmuir. So that same equation also holds or also describes the relationship between exposure and the development of drug-related adverse events. It does not account, of course, for idiopathic events, which will occur largely as a result of